Okay, GIT movements, এটা হচ্ছে PY 4.3, very important for short notes. অনেকগুলো শর্ট নোট এখান থেকে আসে, প্লাস এক্সপ্লেন হয়, প্লাস ক্লিনিক্যাল ফিজিওলজি, এই জায়গা থেকে যতগুলো ক্লিনিক্যাল অ্যাসপেক্টস রয়েছে জিআইটি মুভমেন্টস। আই ডু বিলিভ যে তোমরা জিআইটি মুভমেন্টস কিছুটা পড়ে এসছো। মোস্ট কমন মুভমেন্টস দ্যাট ইউ অল অফ ইউ নো, দ্যাট ইজ পেরিস্টলসিস, and sometimes some of you, maybe all of you knowing, that is anti-peristalsis or reverse peristalsis. This you are knowing. Regarding segmentation, have you heard of this term? Segmentation. আমি প্রথমে জাস্ট একটু দেখার চেষ্টা করছি কতদূর অবধি জানা আছে আর কি। How heard of this term? Good. Segmentation, you know. Receptive relaxation, heard of this term? No. Okay, great. So first of all, we need to refer to the first day's first cross-sectional anatomy of GIT, that picture. Just go back over there once and look at Meissner plexus and Auerbach plexus. These are the part of the enteric nervous system. The whole movement that happens in GIT, very important component of that movement is enteric nervous system. There are certain other, first let us have a basic idea what is GIT movements, basically why they are required. So GIT movements is the movement of the parts of the GIT. It may be movement that is happening inside this esophagus, inside the stomach, inside the intestine, large intestine, small intestine, and the main purpose of this movement is helping in digestion and excretion. These two are the main purpose. Suppose we are taking food in our mouth, and if there was no GIT movement, then even after 12 hours, the food will be stuck in mouth. But that doesn't happen because that doesn't serve the purpose. The main purpose is we have to put the food where it will be degraded, digested, absorbed, and whatever rest is there, that will be going out of the system. So that is the reason GIT movement is required. Now the type of the movements are different at different places in the GIT. It's maybe slightly different what is happening in esophagus, maybe slightly different what is happening in stomach, or slightly different what is happening in distal colon or rectum. But remember two terms, law of intestine and polarity of intestine. I will come to them again. Law of intestine and polarity of intestine, they always remain constant. What does that mean? That means that food will always travel from oral to aboral plane. That forward direction, food will always travel in that direction. This is very, very important. Clear, everybody? Now the factors which causes these GIT movements, there are usually three factors that helps in GIT movement. One is the nervous or enteric nervous system. Here vagus nerve comes into play, and also this enteric nervous system comes into play. That is one. Second is hormones, GI hormones. There are a multitude of GI hormones which helps in this. It may be CCK-PZ, last day we have discussed, secretin, it may be, CCK-PZ means cholecystokinin, pancreazymin. It may be somatostatin, it may be gastrin, and all of them have their own role to play. And the third thing which helps in GIT movements, that is the content itself of GIT. Content itself of GIT means the food content, the pH of the food, the solubility of the food, whether the particles are, being degraded, what is the size of the particle, what is the osmolarity of the particle, all these may regulate. So GIT movements, purpose is digestion, purpose is transport of food, purpose is excretion of whatever is left. So this all is the treatment towards food that GIT offers. And regulation of GIT movements by three things. One is nervous regulation or neuronal regulation, of which we have vagal. It is coming from the central nervous system. The other is enteric nervous system. It is there in the picture that I drew on the day one. Then hormonal. It can be many hormones. It can be gastrin, can be CCK-PZ, multitude of hormones, and we will have a separate class on hormone also. That is a separate PY 4.6 or something. And the third one is the contents of the food. So our next 30 minutes will run around this idea only. So before we move on, first thing which we need to know, is there any electrical movement that happens in GIT? Any idea? Any electrical movement? Yes, that happens in GIT. Even if you are eating something or not eating something, that means in fed state and fasting state. Fed state মানে কি? যখন খাবারটা পেটে রয়েছে। Fasting state মানে কি? দুটো ফেডের মাঝখানে। আমরা তো একবার খাবো, then maybe 2 hours, 3 hours after, till within this period we are not eating anything. Again we are eating something. So in between is the fasting state. আর at the time যখন আমরা খাচ্ছি বা just তারপরে adjacent টাইমটা হচ্ছে fed state. So during this both period, all the time, there is some electrical activity happening in GI system. And this electrical activity is known as basal electrical rhythm, BER, short note আসে। আমরা যাচ্ছি এটা নিয়ে ফার্স্টে। তাহলে এই আইডিয়াটা ক্লিয়ার হয়েছে যে আমরা কি করতে চলেছি next 40 minutes? Everybody got the idea, the purpose of the movement and the regulatory function of the movement. Now we are going to what are the movements? So first is basal electrical rhythm, we call it BER. Basal electrical rhythm. So what is this? Any idea what is this? কি হতে পারে এটা? BER যেটা, এটা কি? Okay. BER is the, হ্যাঁ কিছু বলবে? হ্যাঁ জোরে বলো, জোরে বললে জোরে বলো। Oscillation. Oscillation of, তুমি অসিলেট করছো, একবার দাঁড়াচ্ছ সোজা হয়ে, একবার উল্টে যাচ্ছ, দিস ইজ অসিলেশন, আবার অসিলেশন। টু সিট ডাউন প্লিজ। এবার বলো, এবার বলো। হ্যাঁ, সো বেসিক্যালি ও ঠিকই বলেছে, মানে বলতে চাইছে ঠিক, দেয়ার ইজ আ ফ্লাকচুয়েশন ইন ইলেকট্রিক্যাল স্টিমুলি কন্টিনিউয়াসলি, মোস্ট লাইকলি এটাই বলতে যাচ্ছিল। আর কিছু? টনিক কন্ট্রাকশন এক্স্যাক্টলি নয়, টনিক কন্ট্রাকশন এক্স্যাক্টলি নয়, বাট বেসাল ইলেকট্রিক্যাল রিদম can lead to tonic contraction. Exactly এটাই কেবলমাত্র নয় আর কি। আচ্ছা, এনিথিং এলস? বেসাল ইলেকট্রিক্যাল রিদম মানে তোমরা সবাই এখানে এসে বসে আছো, দ্যাট ইজ বেসাল ইলেকট্রিক্যাল রিদম। এর মধ্যে একটা পার্সেন্টেজের মাথায় ঢুকছে আর একটা পার্সেন্টেজের মাথায় ঢুকছে না জিনিসটা। ইরেসপেক্টিভ অফ মাথায় ঢুকছে কি ঢুকছে না, সেটা হচ্ছে বেসাল ইলেকট্রিক্যাল রিদম। ক্লিয়ার? কেউ কিছু বলবে? বোঝা যায় না কোন জায়গা থেকে শব্দ আসছে আর কি, এটা একটা সুবিধা, তোমাদের জন্য একটা সুবিধা। এক্স্যাক্টলি। এনিওয়ে, সো বেসাল ইলেকট্রিক্যাল রিদম এটা হচ্ছে ফ্লাকচুয়েটিং রেস্টিং মেমব্রেন পোটেনশিয়াল অফ এন্টেরোসাইট, বা তুমি বলতে পারো যে জিআই সিস্টেমে যে সেলগুলো রয়েছে তাদের ফ্লাকচুয়েটিং রেস্টিং মেমব্রেন পোটেনশিয়াল ইজ বেসাল ইলেকট্রিক্যাল রিদম। Why fluctuating? Because the baseline of this RMP, it fluctuates. Baseline টা কত? নিউরনের RMP কত হয়? -70. Good. Skeletal muscle RMP কত হয়? -84 to 90. Okay. Okay, -90 ধরলাম। আচ্ছা, RBC RMP কত হয়? Resting membrane potential RMP, RBC? Any idea? +10. নতুন শুনলে? Yes, +10 আসতে পারে কখনো একটা MCQ তে, just connected to this. So basal electrical rhythm যেটা, এটা usually fluctuate করে -45 millivolt থেকে -65 millivolt. And whenever, even in cardio, even here, যখনই তুমি পাবে there is a fluctuation between the baseline, that means all the time these cells are prone to excitation. যখনই ফ্লাকচুয়েশন থাকবে, সো কি হচ্ছে, থ্রেশহোল্ডটা সবসময় আপ ডাউন করছে এর ক্ষেত্রে। তো এনি টাইম ইট ক্যান বি প্রোন টু আ ফার্দার জেনারেশন অফ অ্যাকশন পোটেনশিয়াল। তো একটা অটো এক্সাইটেবিলিটি, দিস অ্যাকচুয়ালি লিডস টু আ কাইন্ড অফ অটো এক্সাইটেবিলিটি। এটা আর কোথায় পাওয়া যায়? ইন হার্ট উই ডু গেট ইট। কোথায় পাই? ইন দি সাইনাস নোড, ইন দি এভি নোড, মানে পেসমেকার সেলগুলোতে। সো বেসিক্যালি একটা পেসমেকার এবিলিটি রয়েছে এই সেলগুলোর, এন্ড উই কল দেম, যেখান থেকে বেসাল ইলেকট্রিক্যাল রিদম ইজ অ্যাকচুয়ালি সোর্সড, সেইটার নাম হচ্ছে anybody yes, the cells of Castle. So এটা হচ্ছে the source of basal electrical rhythm. So fluctuating RMP which is sourced from interstitial cells of Castle in enterocytes is basal electrical rhythm. That's the basic thing. So all the time there is some kind of electrical agility we can find inside the intestinal cell or inside the gastric cell. Clear? Eta ki contraction kore? Does it lead to contraction? No. Over and above the basal electrical rhythm, we find occasionally more and more accumulation of voltage, sudden burst of depolarization, and we call them spike potential. তাহলে পুরো পিকচারটা যদি আমি পাই, তাহলে the picture looks like this. If we measure the resting membrane potential and the whole voltage activity, there is always some fluctuation in the voltage activity. And this is the basic or basal electrical rhythm. There is something going up and something coming down. Usually this going up is due to calcium influx and coming down is due to potassium efflux. It is same idea, going upwards, it is depolarization in basal electrical rhythm. Coming downwards is the repolarization in the basal electrical rhythm. Ions who are responsible for this calcium influx is responsible for depolarization. Potassium efflux is responsible for repolarization. Does it lead to contraction? No, but there is occasional fluctuation and occasional, burst of activity over and above this basal electrical rhythm, and this leads to further stronger depolarization, and we call it spike potential. This picture is very important. Spike potential can happen due to multiple factors, maybe more influx of calcium ion, which may be channelized by neuronal factors or may be channelized by the hormonal factors. So whenever this spike potential is present, this spike potential leads to further contraction. So spike potential leads to contraction of muscle. Contraction of muscle. Usually, this thing is increased by parasympathetic neurotransmitter. So acetylcholine increases the rate of BER and rate of spike potential, and sympathetic system reduces the rate of BER and rate of spike potential. So noradrenaline or norepinephrine reduces the BER. These are the terms which we will expect in the paper. So you have to write these terms actually in the paper. এগুলো থাকলে মার্কসটা উঠবে। আমরা অলরেডি জানি যে প্যারাসিম্প্যাথেটিক সিস্টেমটা কি করে। প্যারাসিম্প্যাথেটিক সিস্টেম ইজ গ্যাস্ট্রোটনিক. Parasympathetic system increases all the fluids inside the GI system, increases the digestion, increases the movement, whereas sympathetic is just the opposite. And here you can come to the fact that parasympathetic at the very baseline, ACH increases the BER and norepinephrine reduces the BER. এই জায়গা থেকে পুরো জিনিসটা ফর্ম হচ্ছে। ক্লিয়ার এভরিবডি? হলো? আচ্ছা, এবারে নাম্বার এই যে BER হচ্ছে and over and above on top of BER, we are having this spike potential which leads to contraction. Now the number of contraction is also very important. How many numbers, what is the rate of contraction? Remember one thing, the abnormal it goes, the number of contraction increases. তোমাদের সংখ্যাটা মাথায় রাখতে হবে না, আমি যদিও লিখে দিচ্ছি, but nobody is expecting you, but understand the law behind it. The distal it goes, the more number of contraction. So if we look at the number of contraction, it is 3 per minute in case of stomach, approximately 10 to 12 in case of terminal ileum, and almost 16 in case of colon. So you can just 16 per minute. These are all per minute. This is also per minute. So these are gross basal contraction that happens, and the number or frequency of this contraction increases, the more it goes further. তার পিছনেও একটা ন্যাচারাল ল আছে। স্টমাকের ক্ষেত্রে we need more mixing and more degradation, whereas in colon we need more expulsion. সেই জন্য নাম্বারটা কোলনে যাওয়ার পরে অ্যাবজর্পশন রেটটা কমে যাচ্ছে, এক্সক্রিশন রেটটা বেড়ে যাচ্ছে। সো ইউ ক্যান সি দ্যাট ওয়ে ইট ইজ হ্যাপেনিং। ফুড যত কমপ্লেক্স থাকছে, দ্য এরিয়া ওয়ার ফুড ইজ মোর কমপ্লেক্স, number or frequency is less, because at that area food should be in contact with the surface for longer period. ওকে তো ব্রেকডাউন করতে হবে। আর ফুড যত সিম্পলিফাইড হচ্ছে, the emptying speed is increasing. Clear everybody? এই আইডিয়াটা একদম বেসিক। Next, so this is about the beer, and this usually is present all the time. This usually is present all the time. But there is something which is more important. We call it migratory motor complex. Migratory motor complex. What is that? MMC. এটাও কিন্তু শর্ট নোট। MMC কখন আসে? Have you heard of this? আগে শুনেছো? আগে শুনেছো? মাইগ্রেটরি মোটর কমপ্লেক্স। কোশ্চেন এগুলো প্রত্যেকটা আসবে। এটা ওটা এসেছিল? আচ্ছা, তাহলে তো তুমি জানো, তুমি বলতে পারবে। তাহলে তো আরো ভালো কথা, তাহলে তো আরো ভালো কথা। যাকে সো মাইগ্রেটরি মোটর কমপ্লেক্স এই জিনিসটা হচ্ছে যখন ইন্টার ডাইজেস্টিভ ফেজ থাকছে, মানে ফাস্টিং ফেজ, when the stomach is clear, when the intestine is clear, it doesn't have any food inside. Even at that time, it is not at rest. Even at that time, there should be certain movement in the intestine. Reason এই কারণে, even if all the foods are broken down, foods are digested, even then, the debris from food that still remain, the remnants of food digestive products that still remain. And if they are there for a longer period of time, there will be further, accumulation of bacteria, further accumulation of substances which are harmful for our body. So even during interdigestive phase, fasting phase, continuous sweeping movement must be present inside the intestine. So this is basically migratory motor complex. It is a sweeping movement throughout the long segment of intestine, throughout the long segment of intestine during interdigestive period. This is very important, and this is the thing we will be asking you. Interdigestive period. This is known as migratory motor complex. Remember one thing, once you finish this line, the next line will be, it stops the moment food reaches the intestine. So খাবারটা নেই পেটে, কিচ্ছু নেই, খালি পেট রয়েছে, তখনও দেখবে occasionally you feel, when your stomach belly is completely empty, occasionally you feel some kind of cramping. দেখেছো তো, long stretch, occasionally we do feel, occasionally we don't feel, basically. So even at that time, MMC is happening. Understood? And the moment food reaches the stomach or food reaches the intestine, it stops. সাথে সাথে অন্য ফাংশন গুলো শুরু হয়ে যাচ্ছে। That may be peristalsis, that may be tonic movement, that may be segmentation, that may be pendular movement, depending on the scenario. But MMC is the thing, when there is nothing useful, MMC remains. And the moment it stops, MMC stops. Function of MMC. And before that, usually remember, MMC continues, MMC causes a complete overall of substances in a 90-minute period. একটা মোটামুটি 90 মিনিটের পালসে এমএমসিটা হয়। সো আমাদের দুটো খাবারের মধ্যে যদি 3 ঘন্টার গ্যাপ থাকে, এটা 90 মিনিট ধরে অল থ্রুটা পালসটা হচ্ছে, মানে পুরো আপ টু ডাউন যতটা জায়গা রয়েছে পুরো জায়গাটাকে ক্লিয়ার ডাউন করছে হচ্ছে এমএমসি। হোয়াট আর দ্য ফাংশনস অফ এমএমসি? ফার্স্ট অফ অল, propulsion of food remnants. Propulsion, this is the function of MMC, propulsion of food remnants. Then expulsion of bacteria. Expulsion of bacteria. So this way, it also helps in, to some extent, immunity or to some extent protection of our body. Because if the food is stale and if it is remaining in a place for a long time, definitely the bacterial accumulation will happen over there. Usually, every 90 minutes, there is a new wave of MMC. New wave of MMC. Till food reaches intestine. So যদি আমি পেট খালি রাখি প্রতি 90 মিনিটে একবার করে নতুন সাইকেল এমএমসির হবে। এর মধ্যে তুমি যে মোমেন্টে খাবারটা খেয়ে নিচ্ছ সাইকেল স্টপস ওভার দেয়ার। ক্লিয়ার এভরিবডি? যদি খাবার না খাও 12 ঘন্টা ধরে, if you are fasting for 12 hours, MMC will continue. Every 90 minutes, a new cycle. Every 90 minutes, a new cycle. That's the basics behind this. Clear? Stages of MMC, there are 4 stages. There are usually 4 stages or 4 phases basically. So MMC phases. Phase 1, phase 2, phase 3, phase 4. Phase 1 is almost resting phase. Minimal or no electrical activity. Minimal or no electrical activity. Electrical action, মানে এটাকে activity করে লিখবে তোমরা, আমার তাড়াতাড়ি লিখবার জন্য। Minimal or no electrical activity. Phase 2, some electrical plus mechanical activity. So mechanical activity means intestine contraction is happening, intestinal movement is happening, and debris movement from point A to point B is happening at this time. Phase 3, maximal electrical and mechanical activity. So maximal electrical and mechanical activity. Phase 3. Phase 4, again, reduced or very reduced mechanical or electrical activity, and ultimately phase 4 overlaps with phase 1. So phase 4, phase 1 ke khub ekta differentiate kora jay na. Definitely from phase 3 it again goes back to the normal. Enters, it stops. Again, feeding part is over, then it again starts from phase 1. Clear everybody? If no food enters, after phase 4 again goes back to phase 1 and the whole cycle repeats. The whole cycle timing is phase 1 to phase 4 to complete is 90 minutes. Clear everybody? Hormone which helps in it, there is one particular hormone which helps in it, gastric hormone called motilin. So motilin is facilitatory to, or motilin influences, you can write motilin influences the rate and occurrence of MMC. Motilin influences the rate and occurrence of MMC. জিনিসটা মনে রাখাটাও সুবিধা, motility means movement. So ওই থেকে এসছে। Motilin increases the rate of MMC. এইবারে আমরা নেক্সট টপিক, এটা কমপ্লিট করো। Any query so far? So this is the basic idea, the basic electrical nature of the movement. এবারে আমরা স্টেপ বাই স্টেপ ঢুকবো। পার্টিকুলার আমরা বইতে এগুলো খুব ভালো করেই দেওয়া আছে। শর্ট নোট যে জায়গাগুলো আর যে জায়গাগুলো ডিফিকাল্ট আছে, I will keep on explaining. Other areas you just go and 2 times read this topic from textbooks. শর্ট নোটের জায়গাগুলো মানে বইতে প্রচুর লেখা, কয়েকটা জায়গা থেকেই শর্ট নোট আছে। তার মধ্যে কি কি শর্ট নোট আসতে পারে? MMC is a short note, BER is a short note. This two already দুটো শর্ট নোট আমি বলে দিলাম। এই দুটোতেই এই ফেজগুলো বলতে হবে। BER এর ক্ষেত্রে you have to draw the picture, যে গ্রাফটা একটু আগে এঁকেছি, you need to do that. আচ্ছা, এটা কমপ্লিট হয়ে গেছে মোরাললেস প্রত্যেকের? মুছে দিচ্ছি। So next we are coming to the exact feature of movements. So first we are in the upper zone. So upper zone e movement er moddhe ki ache? One is mastication. If we look at mouth and esophagus, movement at the upper part of the GIT, mouth and esophagus, one is mastication, the second is deglutition. One is mastication, the second is deglutition. And deglutition also has three phases. One is buccal phase, one is pharyngeal phase, and the other is esophageal phase. এর মধ্যে কয়েকটা জায়গা ইম্পর্টেন্ট, কয়েকটা জায়গায় ডিফিকাল্ট মলিকুলার লেভেল উই নিড টু রিচ। আদার এরিয়াজ ইউ ক্যান রাইট ফ্রম ইয়োর কমন সেন্স। তো এটাকে আমরা কুইকলি মুভ অন করবো এই জায়গা থেকে। Okay, so you all know mastication, what that is basically. Mastication and what are the part? Mastication is more or less voluntary. Mastication requires the grinding movement of teeth. Mastication requires the movement of the tongue. And mastication also helps in apposing of the upper and lower pharyngeal walls. So basically it's a voluntary and mechanical grinding of things. Also there is some chemical nature associated with mastication because it requires excessive salivation. And that is also happening because of all the reflexes যেগুলো বলেছি। খাবার দেখলে রিফ্লেক্স হচ্ছে, স্যালাইভা বেড়ে যাচ্ছে। সিমিলারলি মুখে যখন খাবারটা থাকছে তখনও স্যালাইভা বেড়ে যাচ্ছে। and all this we have already discussed. সেম আরেকটা কোনো ক্লাস চলছে? অল অফ আ সাডেন কি হলো? নাকি খুব ডিফিকাল্ট কিছু বলছি, ইউ নিড আ পারসন টু কমেন্ট্রি কন্টিনিউয়াসলি, এরকম কিছু? somebody is translating, একজন চলে আসতে পারো এখানে, যেটা বলবো আরেকটা ল্যাঙ্গুয়েজে বলে দেবে, দ্যাট ক্যান অলসো। এরকম অসুবিধা থাকলে we can start this service also. Okay, so mastication গেল। coming to the deglutition, আর এই মাস্ক পরলে তো বোঝাই যায় না, দ্যাটস আ ফ্যান্টাস্টিক থিং। এর থেকে ভালো কিছু হয় না। আমিও পরের দিন মাস্ক পরে আসবো, একটা রেকর্ডিং বাজিয়ে দেবো, ঘুরে বেড়াবো, দ্যাটস ইট। এটিপি খরচা কম হবে। সো mastication গেল। ডিগ্লুটিশন, ডিগ্লুটিশনের মধ্যে ফার্স্ট ফেজ হচ্ছে বাক্কাল ফেজ। এখানেও বিশেষ কিছু বলার নেই বাক্কাল ফেজের ক্ষেত্রে। ডেফিনেটলি lubrication is required, initiation of movement is required, which is initiated, buccal phase initiated by the initiation এর মধ্যে vagus nerve stimulation, সেটা একটা ইনিশিয়েট করছে। salivation is required, definitely pharyngeal is also like that, there is some excessive salivation that is introduced by the excessive physical movement of the jaw and tongue and stuff, and vagus. So basically এই পুরো জোনটাতে up to this movement, I mean factors which is increasing this or factors which is stimulating this, one is presence of food, movement of teeth, mouth, tongue, jaw, and all the apparatus which is present over there. And definitely the third one is the vagal stimuli. এই প্রত্যেকটা মিলে এই জিনিসটাকে করছে। So up to that is the regulatory function. Coming to the esophageal phase, that is very important. Esophageal phase-টাকে আমরা continuously এখন করব। First of all, esophageal phase যখন আমরা শুরু হচ্ছে, এটা হয়ে গেছে কমপ্লিট টাইম নাও। esophageal phase is important, এটা আবার শর্ট নোটে আসতে পারে। এখানে কয়েকটা ইম্পর্টেন্ট এরিয়া আছে। esophageal phase, in the upper zone of the esophagus we have an upper esophageal sphincter, in the lower zone of the esophagus we have a lower esophageal sphincter, and lower esophageal sphincter again comes as a short note. সেইটাকে আমরা এখন এক্সপ্লেন করব এই ফেজের মধ্যে। সো মুচ্ছি, we have to move on. কোনটা এগুলো হচ্ছে মুভমেন্টস অফ, যতগুলো তুমি এখানে অর্গান যা যা ভাবতে পারবে সবকটার মুভমেন্টস। জোরে বলো, বুঝতেই পারছি না তোমার কথা। স্পিক আপ। কিসের পর? টাঙের পরে জ। আমি নিজেই লেখা বুঝতে পারছি না বেসিক্যালি। esophageal part, এটা short note এর জন্য ready করো. The moment food enters the esophagus, there is a constriction of upper esophageal sphincter. First of all, so important point এর মধ্যে first হচ্ছে upper esophageal sphincter constriction. Upper esophageal sphincter constriction. তারপরে ব্যাপারটা বোঝো, the moment food enters the esophagus, there are two things which is happening. Suppose the food is here. Now food need to propel down. If food needs to propel down, two things has to happen. So the moment, suppose this is the esophagus normally, whenever we put food in esophagus, there is some stretching of the esophageal fibers at that area. The moment stretching happens, there are two things. One is proximal constriction. The moment stretching happens, stretching leads to proximal constriction and distal relaxation. Distal relaxation. And this is mediated by stretch, response, and local hormones or local chemicals. এই ঘটনাটা যদি হয় যে proximal constriction, distal relaxation, so what will happen? Esophagus will look like this. And the moment distal relaxation is happening, food is propelling further down. Food যখন second positionটায় গেল, in further down position, again there is happening proximal constriction and distal relaxation. So পুরো জিনিসটা হচ্ছে যেখানেই food যাচ্ছে esophagus, suppose food is here, esophagus is relaxed, so food goes down a little bit. The moment food goes down, again proximal constriction which is pushing food further down, distal relaxation which is receiving food from up. Again in the next position, food, so this is local response. Continuously quote every segment, এই জিনিসটা হচ্ছে, তাহলে উপর থেকে আস্তে আস্তে নিচের দিকে চলে আসে. And this happens right from the end of the pharynx up to the almost end of the esophagus. এরপরে একটা জিনিস চলে আসছে, at the end of the esophagus, where esophagus is connected with stomach, there is something called LES, lower esophageal sphincter. Very, very important. এইটা কোশ্চেন আসে. তাহলে এতক্ষণ পর্যন্ত কিভাবে হচ্ছিল? So far, food masticated, food lubricated, food is broken down into multiple pieces. Now food is in the food pipe and proximal constriction pushing the food down, distal relaxation taking the food from up. This is coordinated by local response, local hormone, local nerve, saliva. All these are coordinating this. Now food is almost at the door of the stomach and it is knocking the door at the stomach. Here the door is formed by lower esophageal sphincter. Doorta হচ্ছে lower esophageal sphincter. And who all creates the lower esophageal sphincter? Smooth muscles, crural fibers of diaphragm, crural fibers of diaphragm, and oblique muscle from stomach. Oblique, MS মানে muscle of stomach. These three are causing, or these three are creating the lower esophageal sphincter. Where is it? Yes. Almost same. Gastroesophageal junction e lower esophageal sphincter টা আছে. It's almost the same. তিনটে রয়েছে, মানে কি ডায়াফ্রাম থেকে স্কেলিটাল মাসল সাপ্লাই হচ্ছে, সেটাও এটাকে এড করে রাখছে. At the end of the lower part of the esophagus there is smooth muscle and gastric part that also supplies the oblique fibers of the muscle. So basically these three mechanisms contains this. প্রত্যেকটা নিজস্ব ফাংশন আছে. We are coming to that. Okay. So what is the function of lower esophageal sphincter? First function is it helps to relax the lower part of esophagus and helps propel food to enter the stomach. So first function, smooth entry into stomach. That is the point number one. Now you can explain from here. Smooth entry into stomach. Second very important function, stopping the backflow of gastric contents into esophagus. That is very, very important. Stopping the backflow of gastric contents into esophagus. কখন? যদি কোনো কারণে by any reason If gastric pressure, intragastric pressure increases, then gastric content may backflow. Now this lower esophageal sphincter stops it. And in fact, the oblique fibers from stomach helps this particular function. Clear everybody? তাহলে একটা valve হিসেবে কাজ করছে so that it doesn't go back. Third function, if by any reason intra-abdominal pressure increases, then again gastric content may come into the esophagus. It is also stopped by the lower esophageal sphincter. And more precisely speaking, this is achieved by the crural fiber of diaphragm. তুমি ধরো একটা স্নিজিং করছো, হাঁচি দিচ্ছ বা কাশছো, at that time intra-abdominal pressure increases. তাহলে প্রত্যেকবার কাশতে কাশতে যদি প্রত্যেকবার gastric content esophagus-এ ঢুকতে থাকে, so the lower part will be burnt. Because esophagus doesn't have those tissue structure which will prevent acid-related injury. That is only present in the gastric region. ওই যে পিজি ওই লেভেলের বা মিউকাস সেটা তো ইসোফেগাসে নেই, সেটা গ্যাস্ট্রিক রিজিয়নে রয়েছে, স্টমাকে রয়েছে. স্টমাক is not auto-digested by its own acid. But if that acidic content continuously comes into esophagus, then it will be auto-digested. There will be a lot of harm to the esophageal mucosa. সেইটাকে প্রিভেন্ট করছে তিনটে প্রসেস. One is intra-abdominal pressure. If it is increased, crural fiber of diaphragm is blocking the exit. So nothing is coming. Definitely intra-stomach pressure is also increasing, but nothing is going up. Second, because of the smooth muscle which is present over there, LOA is getting relaxed and food gets inside the stomach. If there is any other reason where intragastric pressure increases, even then it can't come up because of the oblique fibers of the stomach. Clear everybody? Now the factors, ekhane likhe nao, factors favoring LOS relaxation. এটা হচ্ছে MCQ, একটা দুটো করে কোশ্চেন জিজ্ঞেস করবে, or in viva will be asking you for 1 or 2 marks. So factors favoring relaxation of LOS. Number 1, parasympathetic stimulation. Number 1 is parasympathetic stimulation. Number 2 is VIP, vasoactive inhibitory peptide. VIP, if you know VIP, that is also okay. And third is NO. NO is nitric oxide. এটা আরেকটা নাম আছে EDRF বলে, endothelium derived relaxing factor. তাহলে তিনটে জিনিস যেটা ইমপ্রুভ করছে। and parasympathetic, if I am telling parasympathetic, that means ACH, acetylcholine সেম কাজটা করছে, এইটা খেয়াল রাখতে হবে। parasympathetic মানেই ACH, because that's the neurotransmitter of parasympathetic. Question ACH আসতে পারে, don't get confused then. So 3 factors, NO, VIP, parasympathetic stimulation relaxes the LOS. So if LOS is not relaxed, food will not go down and you will have an ample problem that is known as dysphagia. খুব প্রবলেম হবে, এই জায়গাটা মনে হবে ব্যথা করছে, কারণ ফুড তো স্টাক হচ্ছে এই জায়গাটাতে। People will come and complain about chest pain. Most of the time chest pain might be due to some problem in this area. It is not related to heart in many times. With time you will learn how actually we need to differentiate between chest pain happening due to GI issue or chest pain happening due to cardiac issue. That you will learn later. Factors favoring constriction of LOS or factor favoring closure of LOS. Sympathetic stimulation, number 1, sympathetic stimulation. Gastrin, ব্র্যাকেটে একটু লিখে রাখবে, হাই কনসেন্ট্রেশন অফ গ্যাস্ট্রিন actually. Minimal or physiological constriction or physiological level of gastrin doesn't cause this. So high concentration of gastrin. Norepinephrine. Substance P. So this can cause the LOS constriction. Substance to parve P. Just that's the name of the substance. Later you will also know that this is related to pain pathway. Substance P ta pain pathway এর সাথে থাকে, but এখানে just এইটুকু জানলেই চলবে। So here we come to a disease, and this is again a short note. The next, এটা হয়ে গেছে প্রত্যেকের? হয়ে গেছে? তাহলে এলওএস থাকলে কি কি লিখতে হবে? এলওএস রিল্যাক্সিং ফ্যাক্টরস, এলওএস কনস্ট্রিক্টিভ ফ্যাক্টর, মেকানিজম কিভাবে এলওএস তৈরি হচ্ছে, এন্ড হোয়াট ইজ দ্য ফাংশন অফ ইসোফেগাসে। দুটো স্পেলিং হয়, ইসোফেগাসে দুটো স্পেলিং হয়, তো ও দিয়ে শুরু করলে এলওএস বলতে পারো, আর মানে ইন বোথ কেসেস ইউ আর নট অ্যাট লস। গট ইট? ইসোফেগাসে দুটো স্পেলিং, এলিএস ও হতে পারে, এলওএস ও বলতে পারে। বেসিক্যালি এই যে পুরনো নোমেনক্লেচার গুলো ছিল, যেগুলোতে দেখবে এ ই, ওটাকে ই বা এ ও, এটাকে ও করে দেওয়া হয়েছে, যেগুলো পুরনো নোমেনক্লেচার। স্পেলিং অফ অ্যানাস্থেশিয়া দুটোই কারেক্ট, স্পেলিং অফ ইসোফেগাস দুটোই কারেক্ট, স্পেলিং অফ পেডিয়াট্রিক্স দুটোই কারেক্ট। এ ই দিয়েও করতে পারো, আবার ই দিয়েও করতে পারো, জাস্ট বেসিক্যালি। আচ্ছা, পরে ডিজিজটা, এটা আজকের লাস্ট টপিক। এই ডিজিজ যেটা কেউ শুনেছো কিনা, অ্যাকালেশিয়া। হ্যাভ এনিবডি হার্ড অফ ইট? অ্যাকালেশিয়া, এইটা একটা, এটাও শর্ট নোট, কেয়ারফুল, এইগুলো প্রত্যেকটা শর্ট নোট। Achalasia cardia. This is a disease. Disease's main feature, the main feature of disease, the patient will come to you with a complaint of dysphagia. That's the complaint. Patient will complain of dysphagia. Now what is dysphagia, by the way? Dysphagia হচ্ছে একদম বাংলায় বললে খাবার গিলতে কষ্ট। Somebody is taking food, he is gulping food down, he is swallowing the food, and he is feeling discomfort or pain. This is called dysphagia. Clear, everybody? There might be multiple causes of dysphagia. এখন যাতে ধরো জ্বর হচ্ছে, tonsillitis হচ্ছে, that is also a cause of dysphagia. If you have pain over here, if you have some inflammation over here, it can cause dysphagia. Difference between that dysphagia, this dysphagia is, যে dysphagia গুলো most of the time you people experience due to upper infection, upper throat infection, airway infection, সেগুলোর প্রবলেমটা এইখানে আপ। This dysphagia is happening over here. ওই জন্য the patient may come up with dysphagia when ও বলবে যে খেয়ে নিলাম, মনে হলো এখানে একটা কিছু আটকে আছে। The patient will say that there might be something obstructing this area and causing some severe pain over there. কারণ কি stretching হচ্ছে, it is trying to go down but it is not going down. Clear, everybody? Dysphagia নিয়ে আসছে, this is known as, the name of the disease is achalasia cardia. Now where is the disease? The disease happens due to incomplete or limited relaxation of LOS, বা তোমরা যেটা শুনতে চাইছো LES, whatever. So LOS এর lower esophageal sphincter তার relaxation properly হচ্ছে না, that will lead to this dysphagia. Relaxation properly না হলে কি হবে? Food will be stuck over there. Food দিয়ে যাচ্ছ, কি হচ্ছে প্রথমে, কি হচ্ছে, normally even we take this amount of food, it is guaranteed to reach the stomach because of the harmonious action of the whole thing. যাই খাই এইটুকু খেলেও সেটা স্টমাকে যাবে। এদের ক্ষেত্রে কি হচ্ছে, ছোট জিনিস দিলে যেহেতু এলিএসটা রিল্যাক্স করেনি, the gate is closed. Esophagus, the border between esophagus and stomach is closed. So small food that is dislodged over there. Then you are taking the next gulp of food that is still lodged over there. It is not going over there. But the proximal part is doing the coordinated movement. So after a while, what will happen? The proximal part is vigorously contracting, but it is still failed. It has failed to push it to the stomach. So a time will come, lot of food will be accumulated around the LES, over the LES. Now depending on their mass, depending on the overall pressure, some of them might reach into the stomach, but not in a very efficient way. The patient will complain of discomfort and pain in and around this area. Ultimately, if this remains for a long time, what will happen? Suppose normally this is the junction. In such cases, what will happen? The proximal part, the problem is here. It is not opened up. So proximal part slowly becomes dilated and distal part becomes constricted in case of esophagus. So proximal dilation of esophagus, distal narrowing of esophagus, and distal narrowing. It leads to this kind of feature. It leads to this kind of feature. We call it mega esophagus. There is a chance of development of mega esophagus. Mega esophagus মানে esophagus টা বড় হয়ে যাচ্ছে। বড় কেন হয়ে যাচ্ছে? The food continuously lodged হচ্ছে ওখানে এবং ফুডস গুলো ওটাকে ডাইলেট করছে। কনস্ট্রিকশন হচ্ছে রেগুলার বেসিসে, ইসোফেজিয়াল মাসল গুলোর কনস্ট্রাকশন হচ্ছে, মাসল যত কন্ট্রাকশন হবে হাইপারট্রফি হবে। সো বেসিক্যালি যদি আমরা এইগুলোর বেরিয়াম মিল করি, মানে একটা পুরো ইসোফেগাসের এটা নিয়ে অনেকটা পাখির ঠোঁটের মতো দেখতে হয়, বার্ডস বিক ইসোফেগাসও বলে। সো এনিওয়ে, ফর ইউ রাইট নাও দিস মাচ ইজ সাফিসিয়েন্ট। এলিয়াস relaxation failure leading to lodging of extra amount of food at the end of the esophagus and leading to broadening of the proximal part of the esophagus. This happens, this is known as the achalasia cardia. Reason why this happens, the physiology behind it, reason is decreased amount of VIP, decreased amount of NO, and reduced coordination between vagal responses. Coordination between vagal response. So that leads to development of achalasia. Medicine দিয়ে খুব একটা লাভ হয় না, usual treatment is surgery. ওইখানে লোকাল এসোফেগাসের নিচে মাস্কুলার কিছু সার্জারি করতে হয়। সো দ্য অ্যাপ্রোচ ইজ ইউজুয়ালি সার্জারি। ট্রিটমেন্ট ইজ ইউজুয়ালি সার্জারি, বাট অকেশনালি কিছু কিছু ক্ষেত্রে দেখা গেছে, হ্যাভ ইউ হার্ড অফ দ্য টক্সিন কল বোটক্স, বটুলিনিয়াম? বটুলিনিয়াম শুনেছো? হ্যাঁ, অকেশনালি বটুলিনিয়াম ইনজেকশন লোকালি ক্যান হেল্প। বটুলিনিয়াম যেটা করবে নিউরোমাস্কুলার জাংশনে কাজ করবে and those sphincters it can loosen. So দুটো জিনিস, one option is botulinum injection and the second option is the surgery. এছাড়া বিশেষ কাজ হয় না এটাতে, achalasia cardia. Last topic today, সেম জায়গা থেকে GERD, এটা ভীষণ কমন। achalasia is not that common, but GERD is much more common. Daily, day in and day out, you will be getting these patients. এটাও short note, and both things are correct. GERD, GORD, ওই same logic. Gastroesophageal reflux disease. Gastroesophageal reflux disease. মেজর জিনিসটা কি? মেজর জিনিসটা হচ্ছে গ্যাস্ট্রিক কন্টেন্ট, গ্যাস্ট্রিক অ্যাসিডিক কন্টেন্ট, রিফ্লাক্সিং or regurgitating into esophagus. তার মানে কেন হচ্ছে? The reason is incompetent LES. Reason is incompetent LES. কথাগুলো যদি ডিফিকাল্ট লাগে, ব্যাপারটা আবার বলছি। তুমি যখন খাবারটা খাচ্ছ, when the food is going to enter the stomach, LES should be relaxed. But once the food is inside stomach, LES should be constricted so that nothing comes back. In diseases like GERD, LES constriction and closure is hampered. That is insufficient. So যখন food esophagus এ নেই, স্টমাকে চলে গেছে, even at that time a part of LES is still open. That is called incompetent. যদি দরজাটা পুরো বন্ধ না হতো, we'll call it incompetent door. দরজাটা ফুললি ক্লোজ হওয়া উচিত। যখন তুমি ঢুকছো, at that time it should open properly. যখন ভিতরে সবাই হয়ে গেছে and class is running, it should be closed properly. এই জিনিসটা যদি না হয়, ওপেনিং প্রপারলি হচ্ছে না, achalasia, ক্লোজার প্রপারলি হচ্ছে না, সো দেয়ার ইজ আ ব্যাকফ্লো, দ্যাট ইজ GERD. মাচ মোর কমন হচ্ছে GERD। এটা কিন্তু তোমার 10টা পেশেন্টে 8টা পেশেন্টে পাবে GERD সিমটম, বুঝতে পারছো, এখানে আরো বেশি পাবে, কারণ এই উল্টোপাল্টা খাওয়া দাওয়া, তেলে ভাজা এটসেট্রা খায়, আরো বেড়ে যায় জিনিসটা। এখানে মেজর ভাবে এই জিনিসটা হচ্ছে জিইআরডি। মেজর থিং রিজন ইজ ইনকম্পিটেন্ট এলিএস। প্রবলেমটা কি হয়, অ্যাসিড কাইম, অ্যাসিডিক কাইম, সেটা ইসোফেগাসে কাম ব্যাক করছে। And esophageal mucosa, it is not made to withstand the acidic chyme. So definitely there is burning, there is chest pain, and mostly related to food intake. Patient will come to you যে আমার অনেক অকেশনালি পেশেন্ট বলবে যে মুখের মধ্যে একটা সাওয়ার সেনসেশন পাচ্ছি, টক রকম একটা জল মুখের মধ্যে উঠে আসছে, or অকেশনালি কন্টিনিউয়াস একটা নসিয়াস সেনসেশন পাচ্ছি। All this is GERD. ক্লিয়ার হয়ে গেল? How to reduce the GERD symptoms? You can do some lifestyle changes. খাবার পর কিছুটা সময় হাঁটা চলা করা, খাবার পর যদি ইমিডিয়েটলি কেউ শুয়ে পড়ে তাহলে what will happen? এলিএস অলরেডি ইনকম্পিটেন্ট, প্লাস শুয়ে পড়ার জন্য গ্র্যাভিটি পুলেই দেখা যাচ্ছে কিছু সাবস্টেন্স উইল গো। খাবার পর কিছুক্ষণ হাঁটলে বা কিছুক্ষণ সোজা হয়ে বসে থাকলে this will not happen. Then caffeine, smoking, alcohol, all this worsens this particular thing. Keeping the stomach empty for a long time, that can also worsen this particular thing. So basically a proper lifestyle, avoidance of certain trigger factors like smoking, highly spicy and hot food, alcohol, caffeine, too much of caffeine. 1 cup, 2 cup, 3 cups, okay, but too much of caffeine, that can cause this, that can cause the constriction of the or incomplete relaxation of the LES. Okay. Plus, after food, between food there should be proper spacing, but not extra spacing. 6 ঘন্টা 7 ঘন্টা পরে খাচ্ছে, skipping particular major meal, এই জিনিসগুলো এটাকে বাড়িয়ে দেয়। And definitely to some extent, stress, psychological stress is also connected to this. A lot of stress, anxiety can worsen this situation. Treatment, proton pump inhibitor can be useful, or ranitidine, H2 blocker can be useful. লেখা হয়েছে এগুলো, আগে আমরা বলে দিয়েছি। GERD তে we can use them. Proton. Occasionally, prokinetic agent like domperidone can also be useful. এইটুকু জাস্ট মাথায় রাখলেই চলবে। How they work, it is beyond the scope of today's class. So usually মাথায় রাখবে যেগুলো আমরা দিই, H2 blocker, proton pump inhibitor, occasionally domperidone. These are the things, these are the medication we can use along with lifestyle changes. That's the most important. Clear, everybody? So we are closing it down today. Next day আমরা এইটা কমপ্লিট করাবো। এটা 4.3 ছিল, তার সঙ্গে ব্রেন গাট অ্যাক্সিস, that will be completed the next day. দুটো জিনিস নেক্সট উইকে কমপ্লিট হয়ে যাবে।
Okay, good morning everyone. So we are in the fag end of lower extremity topics to be covered. Already have the theoretical and the practical thing covered. We already have moved to upper extremity. This is the last topic on lower extremity, which is basically continuations of the previous class of the knee joint, and relevant the clinical thing which was left on that day, which we are covering today. And this is, then it will be followed to the upper extremity lectures in the next week onwards. So you are going for a break during Holi, or you are staying here? Staying or going? Going? Not going? Alright, so maybe just like a couple of you will be going and leaving. So next week we will be going for the theoretical classes on the upper extremity. We are planning for your exam, term exam, on the first week of April. So first week of April will be theory, and the practical class we will be planning. So prepare accordingly. We'll be going to have a full session anatomy lecture classes based on theory exam and the practical exam in the lower extremity and the upper extremity topics, whatever you have covered. So these two topics will be covered for sure, along with the embryology and genetics, which has been covered so far in a theoretical content. That will be like a surfacing in examination as exam question. So whatever the topics or whatever the contents we are covering, that is going to be an exam important areas or exam questions, right? So that's a plan for your next 1 month or so. So this is largely an important joint which we have covered or started talking about, the knee joint, which has got clinical importance. We learned about these particular joint components. We learned about this particular the different areas of the stabilizing factors on these into this particular joint, like capsules and the synovial membrane, and these different types of ligaments which are present, and along with it we call them as intracapsular and extracapsular ligaments. And we understand these two different varieties of the ligaments and their roles in binding this particular joint and likelihood to get injured based on this particular problem into this particular knee joint region. And we mentioned that it is one of the vulnerable most joint in our body which is prone to have injuries. So as a result, we see many of our patients coming with the knee joint problems. Now we talked about this particular ligaments and this particular joint stabilizing factors which is related to it, and we talked about this particular the cruciate ligament, which is also a component, which is ACL and a PCL, two varieties and two components, and the menisci, which is the disc which is fibrocartilage placed in between the tibia and the fibula, tibia and the femur, and their role in reducing the friction when the flexion and extension going on. Now coming to the movements, we just talked about these movements. The prime movements of this joint is bending the joint and unbending, which is flexion and extension, which is one of the commonest thing we must address. Along with that, the clinical importance to this particular joint involves into the two other movements involving here, we call them as the locking and unlocking movement. So locking and unlocking movement takes place in the flexion and extension different phases, and based on this particular flexion and extension, if this locking and unlocking with this particular movement is taking place, we have this particular muscles involved in it, and the sequelae of the things is if you have this particular locking and unlocking faultily taking place, we have a problem in the joint structure and integrity as well. Now coming from this part, we are going to talk about the blood supply of this particular joint. So around this particular joint, we have couple of blood vessels scooping around. So you see this is the knee joint you are looking at in the like anterior posterior view or looking from the front side, and this is like the lateral view of this joint. So you're looking from the sides into this particular picture, and this is from the front view. Now out here we have a number of blood vessels which is present around this particular knee joint. So this particular knee joint, the femur which is present with this artery, we call them as femoral artery. The femoral artery is continued back as a popliteal artery, which eventually goes down to the back of the leg and splits into two terminal branches. We call them as the popliteal artery terminal branches. We call them as tibial artery, and this particular tibial artery splits down into two branches, anterior tibial artery, posterior tibial artery. Several small branches around this particular big arteries gives collateral branches around the knee joint. And this particular collateral branches around this knee joint joins with each other and makes a plexus. We call this particular plexus as anastomosis. And this particular anastomosis is taking place strictly by the branches of the arteries. We call them as arterial anastomosis. Now why this particular arterial anastomosis matters, or why should we know about it? Now we should be knowing this particular joint because this particular joint goes on tremendous folding and unfolding. So if you are folding this particular joint, if you are bending it, this particular artery which is going on the back side of this particular joint usually gets bent as well when you are bending the joint. Now if you are bending this particular joint and this particular artery is also kinked, the blood flow through them is reduced. Now if it is having a reduction of the blood flow going through, the lower part of this leg will be deprived of the blood flow. And if you are taking place for a longer period of time, eventually there will be a changes. We call them as ischemic changes, so which we do not want. So for that reason, there is a naturally occurring bypass tracts are there formed by the different arterial branches around the knee joint to overcome this uncomfortable situation which is arising out of bending of the knee joint. So that's why this particular anastomosis matters. When we have this particular main artery closed, when you are bending it, this artery is closed right now, no blood flow is going through it. So during that time, you need some blood circulation. So that particular blood circulation comes through the collateral branches. So that's why this collateral branches matters. Now, there are every joint into it, and in every joint we have this particular collateral branches existing. Now, into this particular knee joint, why it is important? Because this is the most common joint which goes on bending and unbending. That's why this particular joint matters a lot. Now, you see this particular artery which is going down, femoral artery, and going down here popliteal artery. So there are a couple of branches which is coming from the femoral artery. We call them as descending branch which is coming from high up. So this is coming on the high up, we call them as descending branch which is going down like from the sides. So descending branch which is coming over here gives a branch eventually in the front of this particular knee joint. We call them as superior lateral genicular artery and superior medial genicular branches. Superior medial genicular branches. They are branches coming from the femoral artery. So from two femoral artery, we have this particular superior medial and superior lateral genicular branches coming. There are branches which is coming from this particular popliteal artery. We call them as middle genicular branches. So superior branches and medial branches, basically they are coming from the femoral artery and this particular artery which is known as the popliteal artery. Along with that, this particular popliteal artery splits down into tibial artery, posterior tibial artery and anterior tibial artery. So this particular anterior tibial and the posterior tibial gives a branches, we call them as a recurrent branch that moves up. So this particular branches present on the anterior side, we call them as anterior tibial recurrent artery branches and posterior tibial recurrent branches. They are coming from the posterior tibial branches. Now all these recurrent branches coming from bottom and joining around and making an anastomosis or arterial nexus around this knee joint. Now this particular arterial nexus plays a role when this particular artery is blocked. Through these particular small branches, blood still permeates through because they are still open, they are not closed. And as a result, we get a blood flow around the knee joint which also serves a downward blood flow to the leg which is going beyond that particular joint. So that's why we have this particular arterial anastomosis in the knee joint is important. This is one entity which is kind of matters. Now other thing which is kind of important for us, which have got like we learned about a branch which is coming from the femoral artery, we call them as arteria profunda femoris. So that particular arteria profunda femoris gives a branch which is known as medial circumflex femoral artery and lateral circumflex femoral artery, which is present around the knee joint, which is present around the hip joint and serving this particular hip joint region, the blood supply to it. Now that particular artery which is present as a lateral femoral circumflex artery which gives a descending branch. So that particular descending branch goes down through this particular region and comes through here. We call them as descending branch of lateral femoral circumflex artery which also comes from above and contributes to this particular arterial anastomosis around the knee joint. So in short, we have a knee joint anastomosis. This kind of anastomosis, principally a kind of anastomosis which is a vascular anastomosis, and arteries principally taking place around or taking part into this particular anastomosis. There are several branches coming from several big arteries. So we count the big arteries like femoral artery, popliteal artery, tibial artery. So each of these particular arteries shoots down some branches and these particular branches comes together around the knee joint and makes a plexus. And that particular plexus we call them as arterial anastomotic plexus around the knee joint. Now, what is the significance of this? If the main artery is blocked by any reason, this particular smaller branches serves as a collateral or kind of like a bypass tract to survive that particular area which has been supplied by these main arteries. So it can buy some time. During surgery, during knee folding, this particular joint plays a role. Now there are three major branches which are contributing here. We call them as superior, middle and inferior genicular branches. Superior branches, medial and lateral, coming from the femoral artery or lateral circumflex femoral artery descending branches. Middle branches principally coming from the popliteal artery, and the recurrent branch coming from the tibial arteries, anterior and posterior, and they are making this particular nexus around this particular patella, around this particular knee joint and serving this. So this particular region, blood supply or blood flow matters to us in terms of like an acute crisis when this particular knee joint is not working or knee joint is in a folding situation. Now, coming from the blood supply, which is present to us, the prime functions of the knee joint, or which is extension and flexion, bending and unbending, principally done by these quadriceps muscles and the hamstring muscles. Little bit medial rotation and lateral rotations also contributed by, which is by these hamstring muscles, again semitendinosus, semimembranosus on the medial rotation. Lateral rotation principally done by these biceps femoris, and folding and unfolding, locking and unlocking, we already have talked about that particular entity. Now coming to the innervations to this particular joint. So whatever the big nerves or small nerves, cutaneous or the motor nerves which are present around the knee joint, they give a branch to this particular joint. We call this particular branch joint as articular branches. That means they are supplying the joint. So knee joint articular branch which supplies this particular knee joint, they are coming from this particular main branch like the femoral nerve which serves the cutaneous branch, which serves the articular branch which supplies to this. Obturator nerve which also has an articular branch to the knee joint, so they supply to it. There are branches which is coming from the fibular artery, a fibular nerve and the saphenous nerve and the tibial nerve. So all the nerves which is present around this particular knee joint, they serve or they provide a branch which is known as articular branch. Now what are the functions of these articular branches? The functions of this articular branch is to pick up the sensation, touch, pain, temperature, that sensation is picked up by this. Along with that, we call a special sensation into ear, we call this proprioception, also known as joint position sense. Now what is joint position sense? That means the position of your joint, if it is in a flexed condition, if it is an unflexed, or if it is a bending or medial rotated or lateral rotated, that particular knowledge we can pick up without looking at it. So that particular sensation, we call them as proprioceptions or joint position sense on these particular joints. So this particular nerve also picks up this particular sensation of the joint, how this particular joint is positioned at that particular point, which has been picked up by this particular nerve, relate to the central nervous system and assessed by our brain. Along with that, this particular joint serves this particular vascular channel. So these particular blood vessels which are present around this particular joint, they are also innervated by this nerve. So these particular nerves also innervating these particular blood vessels like the major blood vessels, tibial, popliteal, femoral nerves, they are also receiving this particular smaller tweaks of these particular nerves to receive information from them as well. So this particular innervations on this particular knee joint is important. Now out here is important over here is the same innervations of the joint. Now we have this knee joint and we have this particular hip joint. So this particular hip joint and knee joint, they have a common innervation. Now the common innervation, that means this particular hip joint have the innervation by this obturator nerve. And that particular same knee joint also have an innervation by this particular obturator nerve. So this particular phenomenon of the same nerve serving these two joints, we call them as same nervous branch innervation. Now how this particular innervations of the same nerve, say for example obturator nerve, matters to us. Now matters to us is that sometimes we have an injury to this particular hip joint. So you have a hip joint fracture or hip joint injury or infection, fracture or whatever it is, irritations of the hip joint. Now this irritations of the hip joint is picked up by that particular nerve or branch of obturator nerve, which is articular branch of obturator nerve. Now this particular same obturator nerve gives a branch to this particular knee joint as well. Now the patient who has an injury to the hip joint also feels pain on the knee joint. Now how come it's possible? So this kind of phenomenon, we call them as a referred pain phenomenon, where we have the same obturator nerve supplying to this particular two joints and carries the same impulse and picking up it. So this is the obturator nerve, it gives a branch to the hip joint and it also gives a branch to the knee joint. Now you have an injury to the hip joint and the patient feels pain into the knee joint as well. So the hip joint and as well as the knee joint is paining, whereas the knee joint is perfectly fine, no problem whatsoever. So this kind of phenomenon, the nerve which is supplying or serving the picking up the pain sensation from here, which is going out and getting into brain, and our brain is interpreting it. The brain is interpreting the hip joint is troubled. At the same time, they cannot just like simplify whether it is hip joint only or the knee joint as well. So the brain interprets as the knee joint and as well as the hip joint, both are at trouble. So in case of this particular hip joint injuries, we have or we may have knee pain as well. So this phenomenon we call them as peripheral pain sensation. So this happens in case of the commonly in case of the hip joint along with the knee joint, because of the same innervations coming from the same nerves. Now, moving from these anatomical aspects of the diseases involving this particular joint injuries. As I have mentioned, this particular joint is prone to have injuries. So these particular injuries which is been affecting this particular joint principally affects this particular ligament system and the meniscus. So we have several ligaments, intracapsular and extracapsular. Out here is important here is medial collateral ligament and lateral collateral ligament. So these two ligaments we emphasize on whenever we are addressing about the diseases involving the ligament injury to the knee joint. Apart from this, the collateral ligaments, we have two other sets of ligament. We call them as ACL and the PCL. So we have this ACL and PCL, anterior cruciate ligament and the posterior cruciate ligament as well, which are also prone or vulnerable to injury. Now out of these four entities, medial collateral ligament and lateral collateral ligament, which one is a stronger variety of the ligament? Is it medial collateral ligament or lateral collateral ligament? Lateral collateral ligament is stronger than that of medial collateral ligament. So these particular lateral collateral ligament injuries are less, medial collateral ligament injuries are more. Compared to the ACL and the PCL, which one is the weaker variety? ACL or PCL? Anterior cruciate or posterior cruciate? Which is commonly been picked up by the injuries? Which is more injury prone? ACL. So this ACL is more injury prone. So in a clinic, you will be getting this particular patient who has this trouble to this particular knee joint. They are most commonly coming from this particular medial collateral ligament injury and ACL injury. Now out of these two, the medial collateral ligament and the lateral collateral ligament, which of these two have a very intrigued relationship with the meniscus? Medial collateral ligament or lateral collateral ligament? So I repeat, out of these particular two, medial collateral ligament and lateral collateral ligament, out of these, which one has most intrigue or very close relationship with these menisci? We have two menisci, right? What are the menisci? Medial menisci and the lateral menisci. So which one having more intrigue relationship with this ACL, with the MCL or LCL? So medial one with the medial meniscus, right? So this particular medial collateral ligament is basically blended with the medial meniscus. So the medial meniscus, which is having a direct fusion or direct attachment with this medial collateral ligament with this medial meniscus. Now what happens with this particular lateral collateral ligament with the lateral meniscus? They are separated. Who separates them? The ligament of the popliteus muscle. is placed in between them. So this popliteus muscle or the tendon of the popliteus is present in between them, and which is inhibiting the fusion with these lateral collateral ligament with this particular lateral meniscus. So this relationship matters to us whenever we are addressing injuries to the knee joint, or the ligament injuries or meniscal injuries to the knee joint. Now you see that. Now, I am standing in the position. So if I am standing or if I am running in this position. So in this particular position, standing positions or sitting, whatever it is, preferably in a standing position or running position. So which side of my knee joint is exposed more than that of the other side? Is it medial side more exposed or lateral side more exposed? So I repeat, I am standing right now, or imagine I am running. So which side of my knee joint is more exposed to the exterior? Is it medial side more exposed or lateral side more exposed? Now you can look at yourself as well. So which side of your knee joint is more exposed? Lateral side. So whatever the blow that comes to the knee joint comes from the lateral side. So if you are playing a soccer, or just like a running, or just like a walking through, the next to you will be on the lateral side. The medial side, you just like a don't accommodate any person. So whenever you are getting a blow to this particular knee joint, that always comes from the lateral side. And that's why this particular lateral side ligament, which is the lateral collateral ligament, is really strong. So nature has built that in a way, assuming the lateral side is blow prone. So whenever the injuries that coming to this particular, the knee joint, that comes from the lateral side, be it soccer side tackle, or be it any blow from the side, we're coming from the lateral side. Now whenever you have a blow to the lateral side survives that blow because it has a strong lateral collateral ligament. So it survives the blow. But the blow remains, it gets transferred. So this particular blow which is received from the lateral side gets transferred to the medial side. Now once this blow, the pressure comes to the medial side which is transmitted, that medial side ligament bears that. And that particular medial side ligament, which is known as medial collateral ligament, is a weaker ligament. And that breaks. So you have a breakage of the medial collateral ligament. Now that story doesn't end there. So you have a breakage of the medial collateral ligament. Now what's the speciality of the medial collateral ligament? The medial collateral ligament is fused with another thing. What another thing is medial collateral ligament is attached to? The medial meniscus. That means the medial meniscus is also torn along with these injuries to the medial collateral ligament. So one blow, two gone. So we have lost this medial collateral ligament which is a weaker, that is falling short, and again we have this medial meniscus which was fused with this medial collateral ligament that also breaks, snaps. Now we have a weak part of the medial side. Now we have a weak joint on the medial side that makes this particular knee joint very unstable, and then the medial collateral ligament and the meniscus which is been lost by that individual loses the balance and it twists it. Now once it twists or rotates, it snaps the cruciate ligament which is weaker. Which one is weaker? Which cruciate ligament is weaker? ACL or PCL? ACL. The weaker priority again falls. So it also rips the ACL. So you see that a single blow, three fallen. The medial one is the more vulnerable side of the knee joint. Blow is coming from which side? Not on the medial side, coming from the lateral side. It gets transformed to the medial side. First one to fall, the collateral ligament. Then the menisci, and then we have ACL, which also snaps because of these rotation injuries on the knee joint. So we have three injuries together. We call this as unhappy triad of knee joint injuries. So the blow is coming from the lateral side, destabilizing the medial side, it makes a twist, and that particular twist snaps this ACL along with it. So three things we have a damage together. That's why we call them as unhappy triad of the knee joint. This has been given in an examination last year. One or two students could explain. We explained the same thing as I have explained these things, whatever I'm doing it right now. Two students. We got an answer to it. And again, this is the commonest knee injury or commonest variety of the knee injury. And this is what you are going to experience in your clinical life. Alright. So, the tear of the tibial collateral ligament, also known as medial collateral ligament, which tears along with these injuries to the medial meniscus, along with the snapping of ACL, three things together, we call them as unhappy triad of knee joint injury. Alright. So, if you have an injury to this particular ACL or PCL, PCL is less commonly injured compared to the ACL. Now, in a clinical examination, you have diagnosed it. So, by doing a clinical examination or clinical test, you have to diagnose whether this particular ACL and PCL is injured or not. So, we do a test, we call them as dryer test. We call them as dryer test as if we are pulling a dryer. So, to test this ACL, we call them as anterior dryer test. To test the PCL, we call them as posterior dryer test. Either you are pulling the dryer or pushing the dryer. So this particular test, we call them as dryer sign test. So, you are holding this particular knee joint like this, bending it, pulling it forward. If it is too smooth to come out, looks like this particular tibia is coming to your hand, that means the ACL is not there. So, this anterior dryer test sign positive, that means we have a ripped ACL. Now, again you are pushing it. You are pushing this particular knee joint in the same position. If this particular tibia is moving too much backwardly, that means the PCL or posterior cruciate ligament is not there and it is going back too much. So, we call them as anterior dryer test sign for this particular ACL tear rupture and the PCL dryer test rupture, which is also indicating about the injuries to the PCL. Now, the dryer test is not given to the examination. It may be just like a giving in a twisted way. The straight way they asked about this particular question, which is unhappy triad. Next time they may be giving the framing the question based on this particular dryer test, which is again the same thing about the ACL and the PCL. Now, the same thing over here if you are judging a meniscus injury. So, the meniscus which is present on the medial side and meniscus present on the lateral side. So, again in the same positions of the knee joint, you have to rotate it. Medially rotate the knee joint, it feels pain or it is too easy or it's a kind of trouble, we have this medial meniscus injury. If you are twisting it to the lateral side, if the knee is paining on the lateral side, the lateral meniscus is having injuries or tear. So, just twisting this particular knee joint by snapping and unsnapping it, we can judge this meniscus injury and this particular ACL, PCL injuries as well. So, this particular test basically figures out or helps us to this particular meniscus injuries which is involving this particular joints. So, these are the two things related to it along with the nerve injuries which are of clinical importance, and this is a diagram picture on a radiology. We give the radiological pictures to identify the bony landmarks in a diagram. So, we give a knee joint x-ray like this and ask you to identify the different parts of the bones, which is like a 3 marks or 4 mark questions. We give usually pointer to it, like just like we give a pointer, say for example over here. So, this is what you are seeing here, the knee joint, upper end of the lower end of the femur, upper end of the tibia, along with this particular, the upper end of the fibula which you are seeing here. This superimposed structure which you are seeing here in the middle of the lower end is the patella. And this is the meniscus which is present in this particular region, lateral side, medial side, in between. This is the knee joint cavity which you are seeing here in the black. This is the intercondylar areas which you are seeing or looking at it. And this particular condyles, lateral condyles, medial condyles placed in this medial side, lateral side as well. So, in a diagram usually it is marked with this particular region, lateral or medial. But looking at it, you can figure it out this particular diagram pictures belonging to the medial side and lateral side by based on positions of these fibula. So if the fibula is present to the side, that will be the lateral side, the opposite side will be medial. So in a diagram, whenever it is given or in X-ray plate, in layman's way we are saying, we have to figure out which is above, which is below, which is medial, which is lateral, just like position yourself, that's the thing. Once you go there, then you interpret and go on. So then you have to figure it out whether you are looking this particular thing from the front side or the back side. Now again, in this particular joint which you are looking at, you have to address whether you are standing in front of the patient or you are looking at the back side of the knee joint. So that helps here to identify whether you are seeing from the front side or not this particular image. So if you are seeing this particular superimposed picture which is of the patella, that means they are in front, and the back side this patellar image won't be there. So again, you have to figure out this medial, lateral, anterior, posterior. Likewise, you have figured out the bone in osteology, medial, lateral, superior, inferior. So you have to just like a decode this particular diagram in a sequential manner, medial, lateral, then you just like have to identify. Again, we are not just going to ask about the diseases out of here. We just like have to identify the borders. Say for example, lateral border, medial border. If you just like giving on the medial border, lateral border, we may ask about position of this particular adductor tubercle will be on which part. So you just like have to write it like adductor tubercle is on the medial side, etc., etc. Head of the femur, you are saying that, or a femur if it is there. So this particular tibia in the front side, you were saying there, we may be asking about focus on this particular center part of the upper end of this particular region of the lower end of the upper end of the tibia, which has that particular bony prominence in the center part, which we are just trying to figure out whether you understand the tuberosity on the tibia on the anterior border or anterior surface, you understand or not, or what attaches to this particular point on this particular tibia or tibia tuberosity. That means the ligament which is attaching to it, that you have to understand, that you have to answer. All right. So this is all about the knee joint and the knee joint related anatomy and the clinical problems related to this particular lower extremity knee joint. So this covers up the lower extremity lectures. Prepare for it, the examination. Last 10 years question, you must prepare the topics and just like to write the question, prepare that for examination. And as this particular superior extremity is going on, so it will be coming with the superior extremity content from next week onwards. Alright, thank you.
About the bone. So, what are the general features of the bone? Who will say me the definition of bone? What is the definition of bone? Go to stand up and tell. Bolo. So what is the definition of bone?
Bone is a non-playable,
Non-playable.
and they provide support and strength to the body.
So it is forming the rigid framework of body. It is a type of skeletal connective tissue. So it has got one matrix which has impregnated some kind of salt. So what are the salt you will get in the bone? What are the salt? Tell me. What are the salt you will get in the bones? ये थोड़ा हटाओ मुझे. So it is a type of, write it down, it is a type of skeletal connective tissue that consists of the intracellular matrix, and in that there would be intervening some kind of salt, inorganic substance. So these are the calcium and the phosphate salt. So what are the calcium and phosphate salt? In the form of calcium hydroxyapatite. Calcium hydroxyapatite. Okay. So it has got calcium carbonate, calcium phosphate. Okay. And also particularly the phosphate stone. Okay. So these are consist of found in bone. Okay. So mainly calcium, phosphate and carbonate. So these are provided in the calcium tablets. Okay. Mainly we are giving, anybody has less calcium, any kind of osteoporosis, anything. So these are the three salt. You see the composition. Okay. So these three are the salt that would be given. So in osteoporosis, what is the fate of the bone? It become porous. Okay, it become porous. So this salt, it would be reduced. And you know there are two type of hormone in our blood which are maintaining the bone homeostasis. Which are they? One is parathyroid, another one is calcitonin. So what is the role of parathyroid?
Increase calcium.
They will increase the calcium. Okay, and calcitonin is found where? Calcitonin is secreted by thyroid gland, and it is the main function is to reducing the calcium level. Okay, so these are the two chief hormones that is metabolizing the calcium. One is calcitonin, another one is parathyroid. Okay. So you all know in physiology what is extracellular matrix? What is extracellular matrix? So in a tissue there are two type of matrix. One is extracellular, another one is intracellular. So whatever the iron, whatever the minerals that are going through the extracellular spaces, okay, that are found in the extracellular fluid. Okay. So what are the function? So write it down. These are the function. First one is movement. So it is acting as a leverage system. So as you know, bones is the center for the attachment for muscle and tendon ligaments. Okay, number one. And it is also moving, forming the joint and helping in the movement of body. So number one is movement. Movement, that is providing the leverage system for skeletal muscle. For giving the leverage system for skeletal muscle, tendons, ligaments and joints. Okay. Then what is the second function? That is mineral homeostasis. Just now I said. Okay. So what are the? It is the storage for calcium, phosphorus. Okay. These are the main storage, and also vitamin D. Okay. That is stored in the bones. So bones act as a reservoir for minerals important for the body like calcium and phosphorus. So first one is movement, second one is reservoir for the minerals. Then the third one is hematopoiesis. So you know from physiology how many type of hematopoiesis? Hematopoiesis means what? Blood cell formation. So which part of bone is helping the blood cell formation? কে তৈরি করে? Bone marrow. Which bone marrow? Where it could be found? কোথায় থাকে? So you have got one long bone. It has got epiphysis, diaphysis and metaphysis. So this red bone marrow would be found in the epiphysis and yellow bone marrow would be found in the bone, that cavity, diaphysis. Okay, so where you will get the RBC? From the red bone marrow, and this white blood cell will be found from this yellow bone marrow. And from where you will get the platelets? What is the precursor for platelets? Very good. Megakaryocytes. Megakaryocytes. So these are the precursors for the all blood cells. Okay, it is doing hematopoiesis. So blood cell formation, storage of adipose tissue. Storage of adipose tissue, that is for yellow bone marrow. So you could say storage for red bone marrow as well as yellow bone marrow. So do you know what is bone marrow transplantation? And we are doing that one? I told you in the first class from where you will get this bone marrow. From which part, which bones in the skeletal system you will get the bone marrow? What? No, but say the particular bone. We have got 206 bones. Who is saying? Iliac crest. Okay, another one is sternum. Okay, so these are the chief part where we will get the bone marrow. And whom we want, who has got this blood cancer. Okay, for them this bone marrow transplantation is very much needed. So blood group should be same and there should be tissue matching. Okay, then only we could do this transplantation. And particularly for the sibling. Okay, for the next offspring. किसी को हुआ है तो उसका ही sibling से we will take this bone marrow. Okay, from the iliac crest, and another one is sternum. All the flat bones. Okay, then what are the other function? It bears the body weight. Okay, then it protects the vital organ like brain, lungs, liver and heart. Okay, so protection of the vital organs. And unlike the other connective tissue, why the matrix of the bone is hard? Why the bone is hard and rigid? Answer is because of matrix. Because of matrix, because it is infiltrated by so many inorganic salt. Okay, so is there any organic substance in the bone? These are the inorganic salt. Organic substance কিছু থাকে bone matrix এ? These are the inorganic substance. You know the chemistry, right? So what is the organic substance that would be found in the bone? Ball? Which protein? Usse? Collagen. Okay, collagen. Which type of collagen? Type 1. ये MCQ में आता है. Okay, type 1 collagen would be found in the bone. Type 1 collagen. And there is some protein like elastin. Okay. So there is one function in the bone that is known as resilience. So resilience, what do you mean by resilience? Means it could withstand any kind of trauma. Okay, it could regenerate or remodel itself. So that is known as resilience. Okay. Okay, so what are the components? First one is it contains so much water. Okay. Then contains no nerve or blood vessels. Contains no nerve or blood vessels. But it is highly sensitive to pain. Why? Although it does not have any blood vessels or nerve, but bone is highly sensitive to pain. किसी को अगर fracture हो गया, there would be tremendous pain. Why? What is the reason? থাকে না তো, নার্ভ সাপ্লাই ব্লাড তো থাকে না, তাহলে কেন পেনটা হচ্ছে? Because of its surrounding membrane that is known as periosteum, which is highly vascular as well as highly nervous tissue. Okay, so there would be so much pain. Surrounded by perichondrium, dense irregular connective tissue. Okay. Then what are the membrane? There are two type of membrane in the bone. Number one, outside and inside, right? So there are two type of membrane. So covering the outer covering is known as periosteum, and the covering which is from the medullary cavity, that is known as endosteum. Okay. And they have, what is the function of them? They have osteogenic property. So how many type of bone cells do you know? আর কিছু? Which is the mother cell or stem cell? Osteoprogenitor cell. Okay, osteoprogenitor cell is the stem cell or mother cell. Okay, it will differentiate to form the osteocyte and osteoblast. And what is the role of osteoblast? Bone resorption. Okay, bone resorption. Okay, that means breaking down the bone. So that would be done by osteoblast. Okay, and which cell are predominantly found in bone matrix? Answer is osteocyte. Okay, and bone forming cell is osteoblast. So they have the osteogenic potential which is essential for growth and repair. So could you tell for male the growth of bone is up to which year? And for female? Means height. Growth of bone means you know that is epiphyseal cartilage is elongate. So that what is the age? 23. Okay, 23. And in case of female, it is approximately 21. Okay, 20 to 21. Okay. So see, this is all about the periosteum. What are the things you will get? It is a dense connective tissue membrane covering the external surface. Number 1, it is a dense connective tissue membrane which is covering the external surface. So where it is absent? Don't see the slide answer. Where it is absent? Articular surface and another bone, that is sesamoid bone. Sesamoid bone is devoid of periosteum. It is one of the characteristics. Okay, it is devoid of periosteum. So absent in articular surface and also sesamoid bone. And there is one very important MCQ, that is known as what is surface fibers. So what is surface fibers? From the periosteum, it sends some kind of fibers towards the matrix. Okay, throughout. So that is known as surface fibers, which are found parallel to the bone tissue. Okay, so it sends perforating fibers. This is very important, write it down. Surface fibers. This may comes as short questions and also MCQ. It sends perforating fibers perpendicular to the bone surface to nail or anchor the cortical bone. So what is the main function? It is nailing or anchoring the matrix or the cortical fibers. This is known as surface fibers. Okay, and it is rich in nerve supply. So that's why we are preserving the periosteum. So the orthopedic surgeon, they have to be very careful to preserving the periosteum. They should not destroy. जो भी surgery होगा inside only the repair of the bone, or they are inserting any nail or anything inside that. Okay, they are not doing any interruption on the periosteum. Okay. So as you know, if there is any fracture of bone, there are two type of things. Okay, first of all, there is immobilization, right? You are doing the plaster. So if that is not correcting, then you will do what? You will operate and you will just close the bone fragments. You will repair it. You will take one X-ray. Okay, after taking X-ray, then everything right, then only they will leave the patient. Okay, and if you will keep any nail or something, again they will ask, come after 3 months or 6 months. So after that, while it regenerates the bone, after they will do the X-ray, then they will take out. And many cases they won't take out also. They will keep that one throughout the life. Okay. So one is open fixation, another one is internal fixation. Okay. So what is endosteum? Endosteum is thin membrane of vascular connective tissue. So you are getting two difference. That one is dense, this one is a thin membrane. Thin membrane of vascular connective tissue lining the medullary cavity and marrow spaces of cancellous bone. So you are chiefly getting this one is spongy bone. Spongy bone or the cancellous bone. Give some example. Where you will get only cancellous or spongy bone? कौन सा bone है? Where you will get the sinus? Pneumatic bone. Maxilla, frontal. Okay, these are the example. Okay, so these are the porous bone or the cancellous bone. Okay, and it has also got the osteogenic potential. So endosteum is chiefly responsible for osteoblast. It gives rise to osteoblast. During repair and growth, so it could preserve during surgery. Again, we are preserving this one, very much important for the bone formation because it gives rise to osteoblast. So what are the composition? This thing already we have discussed. Okay, so like other connective tissue, it has got one ground substance, one matrix, some cells and fibers that would be embedded on the matrix. Okay. So extracellular fluid is infiltrated with, so all of the calcium salts are found in the extracellular fluid. Okay. And this stone I am saying that is known as crystal of hydroxyapatite. So write it down, calcium hydroxyapatite. So it will form some kind of needle like structure, and it would be 20 to 40 nanometer in length. 20 to 40 nanometer in length. Okay, so there is one formula of calcium hydroxyapatite. You see in the books. Okay, so organic components of collagen fibers type 1 and the ground substance gives the plasticity and the resilience. So both ground substance and collagen type 1. These are the organic material. Okay, so what are the other composition? So matrix is about 25%. Okay, water is about 25%. Protein is consists maximum, that is 50%. Okay, and there are also mineral salts are found. And what are the type of cell? This thing already we have discussed. First one is osteoprogenitor. Then next is the osteoblast, osteocytes, and osteoclast. So these are the 4 type of cells that are found in the bones. One thing I have not mentioned, the structure of long bone and short bone. Already I told. Okay, you know the epiphysis, diaphysis, that all thing included in this. So you have to study along with that. So first one is osteoprogenitor cell. First one is osteoprogenitor cell. Okay. So what are the thing you will get? First one is it is derived from mesenchyme. Number 1, it is derived from mesenchyme. Where you will get mesenchyme? Embryology पढ़े हो, general embryology बोलो mesenchyme. What do you mean by mesenchyme? These are the derivative of any type of connective tissue. Okay, these are the derivative of any type of connective tissue. It is mainly found in the embryonic life. Okay, so that is the definition of mesenchyme. Blood cell है mesenchyme से आएगा, bone mesenchyme, cartilage mesenchyme, everything are derived from mesenchyme. Okay, then all connective tissues are derived. Okay, then unspecialized stem cells. So these are unspecialized stem cells. And how they are forming the osteoblast? By simple mitosis. Okay, they undergo mitosis and develop into osteoblast. and they are found inner surface of periosteum and endosteum. So chief which membrane is giving rise to osteoblast? Endosteum. Osteoprogenitor cells short note आ सकता है, ठीक है? Osteoprogenitor cells. So आगे जाके embryology में study mesenchyme. Okay. What is mesenchyme? What is the function? What are the derivative of mesenchyme? So next is osteoblast. So these are the bone forming cell. These are the bone forming cell and found on the surface of the bone. So if you have got this specimen of bone, you could get this osteoblast. Okay. And it has got no ability to mitotically divide. Okay. So whatever the division is occurring, that is because of osteoprogenitor cell. So ये अगर if there is division, what will occur? Suppose there would be again and again there will be formation of osteoblast. What will happen? Bone cancer. Okay, osteoblast अगर divide ही होता रहा, then it would be increased in number. Okay, so there will be bone cancer. Okay. Then next one is, it is also the collagen secretors. These are also the chief collagen secretors. Collagen means type 1 collagen. Skin में कौन type of collagen दिखता है? हैं? কতগুলো collagen আছে? How many type? 4 type of collagen. So in cartilage, which type of collagen? Type 2. Okay, bone type 1, skin type 4. Okay, so these are the type of collagen. Blood vessels में another type of collagen. Okay, so next one is osteocyte. So what is osteocyte? These are the mature bone cells. These are the mature bone cell that is derived from osteoblast. So the number of osteoblast is constant. Okay, it is fixed. From that there are numerous osteocytes. There will be only maturation. Okay, and they do not secrete any kind of matrix material. They do not secrete any kind of matrix material. So they have got the just like the cellular function, like other sites, right? What are the other chondrocyte? Okay, chondrocyte, osteocyte, just same. So they exchange of nutrients and waste product with the blood. So this is the main function of osteocytes. So you make one column, okay, of each and everything: osteoprogenitor, osteoblast, osteocyte, osteoclast. What are the general feature? Each and every difference you make. Okay, this would be one assignment for you. Then next one is osteoblast. First one is absorbing cells from, it is also found on the bone surface. So bone surface, two type of cells we are getting: osteoblast, osteoclast. Okay, and growth, maintenance, bone repair. This is concerned with the growth, maintenance, bone repair. What is bone formation called as? Bone formation called as? Bolo. Yes, it is ossification. That is nothing but ossification. We are studying primary ossification, secondary ossification. This is nothing but the bone formation. Okay, the process. So abundant inorganic mineral salt, that is tricalcium phosphate in crystalline form, that is known as hydroxyapatite. So this is the formula. Ca3PO4 whole 2 OH whole 2. Okay, so this is the formula of calcium hydroxyapatite. This is also known as tricalcium phosphate. And also you could get calcium carbonate, some amount of magnesium hydroxide, and also fluoride and sulfate. Fluoride is chiefly found on teeth enamel, okay, and also the sulfate. These are the chief minerals found in the bone. Okay. So now the ossification. Okay. So what is the bone formation? That is also known as the ossification. The process of bone formation. Ossification may comes as short note. Okay. Ossification very important. You have to tell everything. Intramembranous, endochondral ossification. Where does it take place? Everything. Along with diagram. Okay. So the process of bone formation is known as ossification. Bone formation occurs in 4 situations. When there is a need of bone formation, number 1, formation of bone in the embryo. Okay. Second one is growth of bone until adulthood. So जब तक secondary ossification center unite नहीं होता तब तक growth होता. Okay. Up to until and unless there is a fusion of secondary ossification center, there would be growth of long bone. Then third one is remodeling of bone. कोई fracture, anything will happen, there will be remodeling of bone. Okay. And the last one is repair of fracture. So you see one thing, the mandible. You just compare between the newborn, adult, and the old age. The shape of the mandible is different. So this process is known as remodeling. Okay. So these are the 4 processes where we are having this ossification. Okay. Okay, so formation of bone in the embryo. What is happening? You know, in the embryo all things are cartilage. Okay. So there is a formation, conversion of the cartilage to the bone. So first of all, this occurs during the 6th week of embryonic life. This is important. When the heart will form? अरे कब pulsation, कब cardiac output, मतलब it would be visible in USG. So heart पहले ही form करके beat करना शुरू हो जाएगा. Then when the heartbeat would be, means you could sound that. 8th week of intrauterine life. Okay, 8th week of intrauterine life. And this is the time before that you could abort the fetus. Okay, it's very important. Once the heartbeat appeared, it's very difficult to terminate the pregnancy. Understood? So 8th week there will be appearance of the heartbeat. Okay. Then the bone formation will form when? The 6th week of embryonic life. Okay. So there are 2 patterns. One is intramembranous, another one is endochondral. So where you will get intramembranous? There will be the bones which are chiefly formed from the membrane. Which is ossified from membrane. Clavicle, another one. Mandible. All these skull bone, mandible, clavicle, these are formed from the membrane, not from the cartilage. Okay. क्या हुआ? 3 parts. One is mandible, another one is clavicle, and the third one is the skull bone. Okay. So you could see in the fetus there are so many soft spots. Okay, in the skull. These are known as. Have you seen any fetus, any newborn? The head is, there are two soft spots in the skull. It is not completely hard. So these are known as frontanally. So why that is present? So that it could easily come out through the pelvic cavity. Okay. So that is known as intramembranous ossification. That soft part ultimately go and form the bone. Okay. So there is the formation of membrane to bone. And in this skull bone you are getting so many pneumatic parts. Okay, that is also because of intramembranous ossification. Okay. And what is endochondral ossification? So just replacement of cartilage to the bone. Okay. And this way it is found in the long bone, where you will get in the epiphyseal cartilage. Okay, epiphyseal cartilage. All the long bone epiphyseal cartilage we could get this endochondral ossification. Okay, now in details, what is intramembranous ossification? So the ossification center appear in the fibrous connective tissue membrane. Number 1. Then osteoblast secretes the bone matrix within the fibrous membrane. So here also you are getting the osteoblast, which will secrete the bone matrix. As because there is no cartilage, then how it is occurring? All are doing by the osteoblast. Okay, and then osteoblast mature to osteocyte. So if anybody will ask the short note of intramembranous ossification, these 3 points you have to mention. Okay. So as you know, all the primary center of ossification will fuse before. The age I told for male and female, all would be fused before. But secondary center fusion would be taking lifetime. Just like the xiphoid process, it would be going up to the age of 60. Okay, the manubrium sternum, it would be going up to the age of 40. Okay, so there would be lengthy procedure. Okay, which bone defies the laws of ossification? Lower limb finished now for you? Ball? Head na lower end? Lower end of fibula. Lower end of fibula defies the laws of ossification. Laws of ossification ki bolche? The center appears first, fuses last. যে সেন্টারটা আগে তৈরি হবে সেটা ফিউজ করবে লাস্টে, কিন্তু এটা ডিফাই করছে, সেটা কি লোয়ার এন্ড অফ ফিবিউলা। এটা কিন্তু এক্সামে আসে, ঠিক আছে। আরেকটা আমি বলেছি যে লার্জেস্ট নিউট্রিয়েন্ট আর্টারি অফ আওয়ার বডি ইজ largest nutrient artery of our body, posterior tibial artery. Posterior tibial artery. Ossification থেকে এই দুটো দেয়, ঠিক আছে। Then next is endochondral ossification. Okay, so chondrocyte at the center of the growing cartilage. So it will enlarge and die as a matrix calcifications. Okay, so this thing already I have discussed in the long bone. Okay, so I am skipping this one. You study the endochondral ossification. So what are the structure of compact bone? Okay, these are the features, characteristic features of bone. What you have to write if you see the bone. Okay, number 1. So compact bone consists of 3 systems. One is there is circumferential system. Circumferential system. Number 1. So circumferential system are of 2 types. There would be outer periosteal and inner endosteal. Okay. And there will be Haversian system, that is also known as osteon. So what is the unit of a bone? That is known as osteon. That is nothing but the Haversian system. Okay, and the third one, there would be interstitial system. So these are the three systems you will get in a bone, compact bone. Very easy. Circumferential means outer membrane. So one would be periosteal, one would be endosteal. Okay. Then Haversian system, that is making the unit, that is also known as osteon. And the third one, that is known as interstitial system. So these are the structure of compact bone. Okay. So first one is the circumferential system. So this is very much important. You have to know what are the structure. Okay. So outer system consists of circular lamella, bony matrix that lie immediately beneath the periosteum. So just below the periosteum you are getting first layer, that is known as circumferential lamina. And just like the inner border of endosteum, you are getting endosteal lamina. Both lamina you are getting. Okay, and between the two circumferential system there is Haversian system and interstitial system. So understood? You have the medullary cavity, there you are having endosteal layer. So there you are having endosteal lamina. And most outside you are having periosteum, there you are having periosteal lamina. And in between that you are having two systems, one is Haversian system or osteon and interstitial system. So whatever these two systems would be found between these two circumferential lamina. Okay. So while you are getting any bone, you are getting the cross section. Okay. So you are getting these three things. Outside periosteal lamina, endosteal lamina, in between Haversian system and interstitial system. Okay. So now Haversian system. It also may comes as a question. Okay, so what is Haversian? This is already you taught from class 2. Okay, so tell me about Haversian system. What do you know? Haversian canal क्या होता है? So see, Haversian system consists of Haversian canal. Okay, there would be one central canal. So what are the structure would be going through the canal? The blood vessels, the nerve, the lymphatic and the loose connective tissue. That would be running in the central canal. Now each and every Haversian canal are connecting from the another horizontal canal, that is known as Volkmann's canal. Okay, that is known as Volkmann canal. And now this Volkmann canal, there would be surrounding canaliculi. Okay, and each and canaliculi will make some kind of lacuna. There would be some oblique slit. Okay, so that is known as lacuna. And in each lacuna is known as circumferential lamina. Okay, so we will come one by one. So first of all, it is found between the outer and inner circumferential system. This thing we have mentioned. Okay, how does it look like? It would be long, cylindrical, branching, principal unit. So that is the Haversian system or the osteon. Okay, and it has got a central canal. So just write it down. It has got a central canal from which the vessels, nerve. It has got one central canal from which the vessels, nerve, lymphatic and loose connective tissue passes through. And what is the definition of Volkmann canal? So the Haversian canal, it will communicate with each other, okay, through the transverse or oblique channels. So these are known as Volkmann's canal. Okay, so kitna feature we have got? 4 features. Okay, first one, It would be found between the two circumferential lamina. Second, how does it look like? It would be long cylindrical principal unit. Third one, what is the central canal? So all the nerve, blood vessels, lymphatic, loose connective tissue are passing through. And the fourth one, the two central canals are communicating with each other by the horizontal or oblique line. These are known as Volkmann's canal. Okay. Then next, each Haversian system is formed by successive deposition of bony lamella. Okay. So there would be one by one lamella. Suppose there is a central canal, so it would be surrounded by one after one lamella. How many lamella would be there? 8 to 20. Okay, 8 to 20 lamella there would be, that is known as concentric lamina. Okay, so the lamina contains collagen, many tiny canals. So these are known as canaliculi, which radiate to the elliptical lacunae. So if you see the slide, you will see there will be some radiation. Okay, one canal and there will be some this kind of radiation. So these radiation are known as the canaliculi. Okay, and in the radiation you will get some small spot. So these are nothing but the lacunae. These are the elliptical lacunae. Okay, and in that you will get some star-shaped cell. Okay, so these are known as osteocytes. These are nothing but the osteocytes. So osteocytes are seen between the lamella and the lacuna. So I told the elliptical spot are the lacuna, okay, and the lines, the round lines are known as lamella. So in between you are getting what? Osteocytes. Okay. So that will be found between the lamella and the lacuna, the star-shaped cells. So these are the osteocytes. So these are the characteristic feature. Number one, Haversian system. Definitely you have to mention Haversian system with Haversian canal and concentric laminae of bony matrix. Number one. Okay. Then second one is interstitial lamina. Third one is lacunae and radiating canaliculi, and the fourth one is Volkmann's canal. Okay. Likho, why you are not writing? This is the last slide. So these are the characteristic features of bone. Okay, compact bone. Number one, Haversian system. Haversian system with Haversian canal and the concentric lamina of bony matrix. So see, lamella are how many types? How many types of lamella you are getting? 3 types. Concentric, circumferential and interstitial. 3 types of lamella. Then second one, there is interstitial lamella. Interstitial lamella, there only you are having this intracellular matrix. Okay, there you will have this intracellular matrix. Then third one, there would be lacunae and radiating canaliculi. Lacunae along with the radiating canaliculi. And the fourth one you have to mention, that is known as Volkmann's canal. Okay, so these are the 4 characteristic features that you have to mention. Okay, so now we will see the slide. So see, you won't see yellowish color. You will get which color? Blackish. It will appear as black. Okay. So what are the things you could see? What is this? This is known as central canal. Okay. This system is known as Haversian system. This is known as central canal. So from where nerve, lymphatics, blood vessels and loose connective tissue are found. Okay. Then you are having these lamella. These lamella are known as concentric lamella. Okay. And in between that you are getting these elliptical spaces These are known as lacunae. Okay, and also you will get some kind of cells all throughout here. So that are known as osteocytes. Okay, so could you identify any Volkmann's canal? Tell me which one would be the Volkmann canal. So you could get some horizontal canal, okay, that are connecting to Haversian system. Okay, so these are known as Volkmann's canal. So these are the feature you will see in the slide. See, this is also the same slide. So this one is known as the central canal. These are the lacunae. These are the concentric lamellae. And from here, from one to another, there would be Volkmann's canal. Okay. Now see the slide. Go and see the slide.
Like